Okay, so it's a galactosemia. This patient most likely has galactosemia. This patient has most likely has galactosemia, an inborn error of metabolism caused by deficiency of the enzyme of galactose 1 phosphate uridyl transferase. Galactose 1 phosphate uridyl transferase. Galactose 1 phosphate uridyl transferase is responsible for the metabolization of galactose, which is found in breast milk and cow's milk based formula into glucose. Therefore, newborns with galactosemia develop hypoglycemia and accumulation of galactose. The presentation typically occurs in the first week of life with vomiting, jaundice, hepatomegaly, poor feeding, can lead to lethargic, hypotonia, and dehydration and shrunken frontally. Newborns with galactosemia often do not gain weight, are at risk of E. coli species. Severe hypoglycemia may also cause seizures in the neonatal period. A characteristic feature in about one-third of the patients with galactosemia. Cataracts Cataracts may be present at birth, but more commonly develop during the first few weeks of life as an accumulated galactitol deposit in the lens. With prompt initiation of galactose-free diet, soy-based formula, symptoms typically resolve. Okay, okay. It's also sign. So these patients paresthesia. So these patients paresthesia, carpal spasm, or trossocine. Trossocine is induction of the carpopedal spasm by inflation of the BP cuff above systolic blood pressure for more than 3 minutes. For 3 minutes. And Vostick sign is contraction of the ipsilateral facial muscle elicited by tapping on the facial nerve just anterior to the ear. Okay, just anterior to the ear. Just anterior to the ear. Okay, now so these patients paresthesia, carpal spasm, and hyperreflection in the setting of high volume transfusion. In the setting of high volume transfusion, these neurologic features are most likely due to hypocalcemia. Other potential features of severe hypocalcemia include tetany, laryngospasm, seizures, encephalopathy, and heart failure. Patients with chronic hypocalcemia may have only mild symptoms, but patients with acute hypocalcemia will have more severe manifestation at the same calcium concentration. Citrate is transfused. Citrate in transfused blood binds ionized calcium, which is biologically active fraction. Total calcium level will not be significantly affected. Hypocalcemia is uncommon following blood transfusion in patients with normal liver function, as citrate is rapidly metabolized by the liver. However, the patient likely has hepatic dysfunction due to liver laceration as well as ischemic liver injury due to hypotension. Ischemic liver injury due to hypotension. Other infused substrate that can chelate calcium in the blood include lactate, phoscarnate, and sodium EDTA. I think that is that glycogen storage disease thing. Probably there is hepatomegaly, high lactic acid. Pick anyone. Okay, this is glucose 6 phosphatase deficiency. Hmm. I thought von Garki, but I uh, pick wrong. Okay, von Garki disease, glucose 6 phosphatase deficiency type 1 glycogen storage disease. Von Garki disease is caused by deficient glucose 6 phosphatase. Deficient glucose 6 phosphatase in the liver, kidney, and the intestinal mucosa. The resultant impaired conversion of glycogen, the resultant impaired conversion of glycogen to glucose, leading to glycogen accumulation in the affected organ. In the affected organ, patient typically present at age 3 to 4 months of hypoglycemia, often resulting in seizure and lactic acidosis due to buildup in the liver. Other labs include hyperuricemia and hyperlipidemia. Patients physical examination demonstrate doll-like face with rounded cheek, thin extremity, short, stretch or protuberant abdomen due to hepatomegaly. The spleen and the heart not involved. The spleen and heart not involved. Yes. Glucocerebrosidase enzyme deficiency like Gaucher's disease. We have found a question like Gaucher. Glucocerebrosidase accumulates in the macrophage again like in the liver, spleen, bone marrow causing bone pain and cytopenia. Gaucher bone marrow cytopenia and in their hepatomegaly also is present but hypoglycemia and lactic acidosis are not typical. And the inability to break down fatty acid chains inability to break down fatty acid chain is a feature of is a fatty acid chain sorry the inability to break down fatty acid chain is a feature of fatty acid cycle disorder such as medium chain acyl CoA dehydrogenase deficiency, medium chain acyl CoA dehydrogenase deficiency. MCAD results in episodes of hypoketotic hypoglycemia during fasting state, illness, elevated lactic acid, elevated uric acid, and characteristics feature are not typically seen. Okay. Yes. Inadequate total body glycogen store may occur in newborns as a result of prematurity or intrauterine growth restriction. Hypoglycemia is very common in these newborns. However, it is typically occurs with the first 24 hours of life would not persist at the age 4 months and would not be associated with specific facial features. Okay. Sorry. He has operation. After operation, he is anxious and agitated. He is alcoholic. Dantrolene for like during operation, if you give the halothane, oh, it's I lost. We actually both ignore these two facts, like for tremor and the lead lag. So if we are very concerned with the CK, but there is fine tremor and mild lead lag, so looks like thyroid storm after surgery. Okay, so clinical feature first with the box as we have done wrong in both. Okay, clinical features of thyroid storm: thyroid or non-thyroidal surgery, acute illness, trauma, infection, and childbirth, and acute iodine load, iodine contrast, fever as high 104 to 106. This patient does not have that fever. No. Okay, 103. Okay, there is tachycardia, fever, tachycardia, hypertension, congestive heart failure, cardiac arrhythmia, agitation, delirium, seizure, coma, agitation, delirium, seizure, coma, goiter, lead lag, tremor, worm, and moist skin, and nausea, vomiting, and diarrhea, and jaundice. So treatment is beta blocker, that is propranolol to decrease the adrenergic manifestation, PTU followed by iodine solution, PTU followed by iodine solution to decrease hormone synthesis and release, glucocorticoid, hydrocortisone to decrease peripheral T4 to T3 conversion and to improve vasomotor stability, and treatment identify, trigger, treat, and supportive care. Okay, this patient presentation is concerning for thyroid storm, a life-threatening thyrotoxicosis easily triggered by a specific event, thyroid or non-thyroid surgery, trauma, infection. In patients with undiagnosed or inadequately treated hyperthyroidism, proposed mechanism include a rapid increase in serum thyroid hormone level or increased sensitivity to thyroid hormone. Characteristics feature include tachycardia, hypertension, cardiac arrhythmia, atrial fibrillation, and fever up to 40 to 41 degrees Celsius. And other findings include anxiety, altered mentation, seizure, severe nausea, vomiting, hepatic dysfunction, tremor, lead lag, and goiter. Diagnosis is suspected clinically and confirmed by thyroid function studies documenting hyperthyroidism. Treatment includes beta blocker, propranolol for symptom control, INMIDs to block new hormone synthesis, iodine solution to block thyroid hormone release, and glucocorticoid to decrease peripheral conversion of T4 to T3. Okay, yes. IV dantrolene to treat malignant hyperthermia, a hypermetabolic syndrome due to volatile anesthetic leading to sustained muscle contraction and breakdown. Malignant hyperthermia presents with hypercarbia, sinus tachycardia, muscle rigidity, significantly elevated CK, like 10,000, 20,000 elevation of the CK. There is hyperkalemia and hyperthermia. In patient, the presence of lead lag. Lead lag and the absence of muscle rigidity, and the normokalemia, more consistent with thyroid storm than malignant hyperthermia. Her moderate creatinine kinase elevation likely reflects muscle injury related to the trauma or surgery. and IV lorazepam can use to treat alcohol withdrawal, which usually presents with tachycardia, hypertension, altered mental status. Fever is atypical with early withdrawal, but occur with can occur with delirium tremens, which develop 72 to 96 hours after the last drink. This patient history of moderate alcohol use makes withdrawal less likely, and alcohol withdrawal would not explain her lead lag. Okay, his head circumference is what? But stature is second below second percentile. Look at the stature. Mm, I think that low 55 inch. Father may not be. His weight is 39. Is it constitutional? Okay, I don't know either. I just guessed. So, so the short stature defined as height is less than second percentile, but we know that his height is below the second percentile. For sex and age, short stature is most commonly a normal variant of the growth. Normal variant of the growth due to constitutional delay or familial short stature. They have done okay. Wait. Okay, this patient has short stature. This patient has short stature. mm, defined as height less than second percentile for age and sex. Short stature is most commonly a normal variant of the growth due to constitutional growth delay or familial short stature. Constitutional growth delay can be recognized based on delayed bone age with a linear growth velocity starting at age 3 or more than 3. Affected patients typically have normal birth weight and height but show a slow linear growth velocity between age 6 months to 3 years. This patient height is less than second percentile. The growth second percentile. Mm, they subsequently grow at a normal growth delay. So their growth curve remains below but parallel to the lowest percentile line linear growth curve. Are you understanding the puberty? I don't know actually. I am very poor in this growth curve. Waste of reading, I think so. Okay, okay. It's your duty to find out the clue. I am just reading as a news reader. Okay, their puberty is delayed and bone age is delayed compared to the chronological age. There is a chart like bone age and chronological age somewhere I have read. Okay. However, they eventually have a normal growth spurt and reach a normal adult height. Management includes reassurance and monitoring of the linear velocity. In contrast to constitutional growth delay, however, these patients with familial short stature have a bone age that correlates with the chronological age. Bone age um, that correlates with the chronological age and puberty is delayed. Although these patients have normal linear growth velocity stable percentile similar to the constitutional growth delay. One or both parents have a short stature unlike in this patient. Or an affected patient adult height remains low. Okay, you tell me. I don't know, so I can make you understand. In my internship, I tried, but I failed. Okay, yes. Okay, patients with growth hormone deficiency have short stature, delayed puberty, and delayed bone age. However, linear growth velocity is slowed typically presenting as declining height percentile crossing two major percentile, 50 and 25s. This patient's height percentile is stable, indicating a normal linear growth velocity. And hypogonadism leading to testosterone deficiency can be congenital or acquired testicular trauma or infection leading. Although delayed puberty is common, bone age would be normal. In addition, most patients have gynecomastia, not seen here, due to negative feedback causing LH and estradiol. Okay. Yes. Glucose is not that high. Maybe. Yes. Glucose in the pee and blood glucose may be high. It's not normal pregnancy stage. In normal pregnancy stage, you take 2 liter and you excrete 5 liter. That's absurd. And she has this kind of problem previously. So looks like DI. Okay. Evaluation of the suspected polyuria. Look at the chart first. Complete 24-hour urine collection. If urine produces more than 3 liter, polyuria present. If it is dilute urine, then water diuresis or primary polydipsia or diabetes insipidus. If dilute urine, water diuresis, primary polydipsia or diabetes insipidus. If it is concentrated urine, then osmotic diuresis, increase solute excretion like glucose, urea, and saline. If it is less than 3 liter, no true polyuria, workup for causes of urine frequency like UTI. So this pregnant patient with polydipsia and nocturia has polyuria, 24-hour urine output more than 3 liter, and her urine analysis reveals a low specific gravity, indicating a dilute urine. Polyuria and dilute urine, polyuria and dilute urine in the setting of normal serum sodium and fluid intake 2 liter suggest diabetes insipidus. DI characterized by an inability to concentrate due to an insufficiency or renal resistance to antidiuretic hormone, which normally increases water reabsorption in the collecting duct. DI can remain undiagnosed because the body often compensates for water losses with demand for increased fluid intake. However, during pregnancy, placentally produced enzyme vasopressin increase ADH breakdown and can worsen symptoms, thereby unmasking the diabetes insipidus. Some women develop transient diabetes insipidus of pregnancy due to an exaggerated response to vasopressin. This phenomenon may resolve with delivery and but recur in subsequent pregnancy. This patient a more complete workup challenge with desmopressin and ADH analog is required to confirm the precise etiology of the diabetes insipidus and central due to insufficient ADH and level versus nephrogenic due to renal resistance of the ADH. Okay. 2.5 to 3. Oh, sorry, 3 to 4.5. 4.5. Calcium is very high. Hypercalcemia. Severe hypercalcemia. Uh, Severe hypercalcemia with hypophosphatemia. Phos- is it milk alkali? And he is on chlorothalidone also. Hyperglycemia, thiazide. Oh, 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 wait. One thing like he has polyuria, constipation. She has abdominal pain. I'm thinking about bones, grown stones, psychiatric overdose, like primary hyperparathyroidism. Sorry, what the? Oh, it fits, isn't it? Elevated, elevated parathyroid. Uh, we have read the one flow chart. You have remembered, like, if it is primary, if PTH is high, calcium is high, that means primary hyperparathyroidism, familial hypocalciuric hypercalcemia, and lithium. These three are for primary cause, and the secondary cause where we need these three. You are talking about parathyroid hormone related peptide. This one, smoking. You are thinking about the lung cancer. In which lung cancer parathyroid hormone related peptide increases? Squamous, but there is no. Oh, he has weight loss. Yes, yes. Uh, Maybe it's not yeah, it's not elevated PTH because there is no bones grown stone psychotic. It may be your answer B. Maybe bone pain. There is no bone pain. There is no abdominal pain. There is no. It is your answer. Yes. It is hypercalcemia of the malignancy. Okay. I was right. Squamous cell. Okay. Okay. Parathyroid hormone related peptide. A parathyroid hormone related peptide increases in squamous cell carcinoma, kidney and bladder cancer, breast and ovarian cancer. Squamous cell cancer, kidney and bladder cancer, and breast and ovarian cancer. Okay, in bone metastasis, everything is low. PTH is low, parathyroid hormone related peptide is low, and vitamin D is low too. And in 125 hydroxy vitamin D, in 125 hydroxy vitamin D, PTH is low and vitamin D is high. Okay. Okay, this patient has polyuria and a neuropsych. This patient has polyuria and neuropsychiatric symptom consistent with hypercalcemia. Severe hypercalcemia can also causes impaired neuromuscular excitability, leading to weakness, diminished reflex, and decreased gastrointestinal motility. In the light of these patients, weight loss, temporal wasting, dry cough, and smoking, he most likely has humoral hypercalcemia of the malignancy due to squamous cell carcinoma of the lung. HHM, like hypercalcemia of the malignancy, is a paraneoplastic syndrome due to release of parathyroid hormone related peptide by the malignant cell, which is structurally similar to parathyroid hormone PTH and acts on parathyroid hormone 1 receptor. PTH parathyroid hormone related peptide causes increased bone resorption of calcium, in the distal renal tubule, and increased phosphate excretion leads to hypophosphatemia. HHM is characterized by severe more than 14 milligram uh, calcium and rapid onset hypercalcemia. The diagnosis is suspected on the clinical ground and can be confirmed by elevated level of parathyroid hormone related peptide level and suppressed PTH. HHM is usually seen in advanced malignancy and confers a poor prognosis. Okay. B1 Korsakov, Warniki Korsakov. Look, he has constipation. Okay, it's hypothyroidism. Although this patient comes Although this patient comes in due to memory problem, severe features of presentation suggest she more likely has hypothyroidism. In addition to memory changes, she has several manifestations of hypothyroidism, including weight gain due to decreased metabolic rate, due to due to matrix glycosaminoglycan accumulation in tissue interstitial spaces, constipation due to decreased gut motility, and fatigue due to overall slowing of the metabolic process. Confirming hypo Confirming hypothyroidism and as an etiology of her presentation is an important because administration of levothyroxine will quickly reverse his symptom. Hypothyroidism presenting as memory problems can sometimes be difficult to distinguish from pseudodementia, a presentation of major depression in elderly. Although this patient has several features of depression, poor concentration, decreased energy, sleep disturbance, weight gain, she does not clearly have depressed mood, or anhedonia. Furthermore, depression would not explain her hoarseness and constipation. Okay, next. HRT actually prevents the osteoporosis, isn't it? Oh, and lack of regular exercise is not. He works as a tour boot operator, spent most of the time in the outdoor. You are right. You were okay. I was a bit confused. Okay, carbamazepine. Carbamazepine is an enzyme inducer, isn't it? Yes, enzyme inducer. Don't you remember the mnemonic? Most. Okay, just listen, then you can remember. Don't try to memorize. Like most chronic alcoholics, refuse fen and never refuse crazy carbs. Most means modafinil. Chronic alcoholics refuse means rifampin. Fen means phenytoin and phenobarbital. And never means nevirapine. Refuse rifampin. Greasyfulvin, and carbs and carbamazepine. Got it? The uh, what I have said all are inducer. And inhibitors has mnemonic like sickfaces.com. I am taking grapefruit juice. Actually, I am very okay. I know how to remember the mnemonic. Okay, so I sometimes I create mnemonic my own. That's why no, it was written in the first aid. Yes, obviously. In the first aid. Okay, okay, I will give you in the because no, I can give it now, but wait, there is some problem. Can you hear me? Oh, yes, my Foxit reader is not working. That is the problem. My reader, where I find the things. Okay, okay. Next. Okay. I haven't read the. explanation. Okay. Okay, cause of vitamin D. This patient has vitamin D deficiency. This patient has a vitamin D deficiency confirmed by a low 25 hydroxy vitamin D level. However, she has a classic risk factor for dietary deficiency, restricted diet, malabsorption, or inadequate dermal vitamin D production, nursing home residents. Patients with adequate source of vitamin D can develop mm, deficiency of excessive catabolism. Catabolism of vitamin D is initiated by cytochrome P CYP cytochrome P24A1, also called 24-hydroxylase, which acts on the both 25 and 125. 24-hydroxylase acts on 25 and 125 vitamin D forms, converting them to inactive form. Carbamazepine and other anticonvulsants like phenytoin induce expression of these enzymes, which can lead to increased breakdown of vitamin D and vitamin D deficiency. Okay. Okay, what are the causes of a vitamin D deficiency? Look at the cause. Inadequate intake, lactose intolerance, milk avoidance. Inadequate intake, lactose intolerance, milk avoidance, and vegan diet, and malabsorption, Crohn's disease, celiac disease, bariatric surgery, gastric bypass or gastrectomy, inadequate sunlight exposure, um, extreme northern or southern lassitude, heavy skin pigmentation, sedentary lifestyle, CKD, CLD, and drugs. Drugs, anticonvulsant, phenytoin, and carbamazepine, isoniazid, and rifampin. Okay, next. Okay, okay, we can stop here.